Thank you so much for the wonderful introduction. I very much appreciate that. So I am going to just let you know that, again, my name is Heidi Koslo, as I was introduced. I have no disclosures, no financial or other interests in relation to my presentation. This is an evidence-based practice guideline on my capstone work for my doctorate. I do have a conviction that human feeding, so breast and chest feeding, is the normal infant feeding method, and that it should be preserved with few exceptions as guided by evidence. And I do welcome any recommendations and feedback from anyone who is watching this presentation. My contact information is at the end. I am happy to take feedback. I appreciate the platform from USBC and feel that they do provide a wonderful framework for feedback in a safe and supportive space as I try and broaden my equity lens and increase my awareness of issues in the world around me. Objectives today particularly include an ability to articulate a little bit of the history and ongoing development of lactation support within the military health system. I would like to briefly analyze and mention some existing policies across branches of the military and discuss the way that they apply to the military currently, and the evidence-based practice guideline can be used to unify those policies across branches. And then also to name the unique challenges of active duty personnel in providing human milk to their infants and their children, as well as their ability to utilize current policy to help overcome challenges based on military duty. The key symbol that I've provided is just a reminder to watch for key points today that may correspond to some of the post-test questions that you will be asked to respond to for credit provided. I'm also looking down a little bit at notes that I have, and I would like to mention that I'm wearing my daughter's basic military training graduation shirt, so that's what all of the symbols are here, POW, MIA, etc. So to introduce the project itself, the purpose or the reason for the evidence-based practice guideline is because there is no current guideline for breastfeeding support for either civilian or active duty families in use at the particular facility where I completed the capstone work, Joint Base Elmendorf-Richardson, or across the Department of Defense and Defense Health Agency as an organization as a whole. There is a strong body of widely publicized evidence on the importance of supporting breastfeeding for the emotional and the physical health of both mother and baby. And I would like to say that while you'll see a lot of the words mother and baby or servicewoman, etc., and that is because that as far as within the military health system, that is still the common terminology. So that is incorporated pretty much within the guidelines that I've created. Now, reinforcing a woman in her breastfeeding goals fortifies the family unit as seen by the military and augments a woman and her family's self-efficacy in providing lactation and breastfeeding for the baby. Self-efficacy particularly influences resiliency, which is a key concept in military readiness. You may be familiar with Roche Paul's work. She wrote the book Breastfeeding in Combat Boots, which is still recommended within the military health system. So a reminder is that increasing military readiness is something that's a key point within the military health system. They incorporate the 3 pillars of IHI's triple aim, those 3 points, and include military readiness as part of the quadruple aim. So balancing cost of provision of services, patient satisfaction issues, health outcomes are all incorporated underneath the expectation of military readiness for servicewomen and service members. An evidence-based practice guideline on coordinating care across the spectrum for the breastfeeding dyad so that all service units are incorporated, in my opinion, should be created and disseminated throughout the Defense Health Agency, which was the impetus for this capstone project. So if you think about, sort of ask yourself, what are the problems, or what is the big problem of not having a guideline or a policy? And so to sort of iterate those for you, and you may think of others as well, the provision of lactation support services has been considered a public health imperative for decades by top organizations, including nursing organizations. Despite that fact, there are very few policies within the different branches that devote more than a few paragraphs at a time to breastfeeding support. But there are health and financial benefits associated with breastfeeding. And so we know that in the broader population, and that applies also within the Department of Defense and the Defense Health Agency. So why is there no consistent policy across the military treatment facilities for supporting military women, military families who breastfeed? So when we're looking at the different policies, I'm just going to briefly address those policies that already exist. They include the Department of Defense's clinical practice guideline, which is what they call their evidence-based practice guidelines for pregnancy management. Breastfeeding is briefly mentioned in there to be covered prenatally. There was an absolutely wonderful standard operating procedure out of Fort Bliss, Texas, at the headquarters of the 1st Armored Division that was actually superseded by a less inclusive or less detailed Army directive, 2015-43. The problem with that one is that they really didn't, they leave a lot up to interpretation, and commanders, command structure is not familiar enough with lactation to really be the ones who should interpret any sort of policy. The Secretary of the Air Force does have an Air Force guidance memorandum, which includes instructions on breastfeeding and breast pumping. Benefits, the TRICARE policy for access to care does provide for benefits for both breastfeeding support and supplies. Depending upon the location, they may be very difficult to access, or families may not know how to navigate that to request those. It exists, but getting to them may be more difficult than would be immediately assumed. So if you're looking at that, you would think, well, that must also include information on where pumping, etc., would be provided. But ask yourselves, what else might have to address that? Yes, they have to have separate policies and information that covers the pumping space, the lactation space, and it's addressed separately. The Air Force, the Coast Guard, the Marines, the Navy have, and others have separate things, separate policies, separate procedures that are not all under one umbrella, making it difficult to access or find that information. Leave policy varies across branches. Convalescent maternity leave, so just the fact that you've birthed a child, 42 days to 12 weeks, depending on branch. Primary caregiver leave can be quite changeable. So primary caregiver meaning however they wish to interpret that, 42 days to 12 weeks. An important and key piece of information, which I think is outstanding, is that the Coast Guard actually allows up to 2 years temporary separation with return to rank. That is only allowed during for one term, but that is a more expansive policy. Secondary caregiver leave, 14 to 21 days or 3 weeks. There is an allowance for single parents in some branches to combine their convalescent maternity leave, their primary caregiver leave, and secondary caregiver leave as well. So when we look at those, something that needs to be thought about is, what obstacles do women face or do families face in accessing that? So we think about the obstacles. Just take a moment to question yourself, what are obstacles that people face in breastfeeding? And how might that be different in the military health setting? So of course, just big picture, inconsistencies in provider training, they contribute to a broad range of problems associated with breastfeeding knowledge gaps, rigid attitudes of providers, your baby's not gaining enough weight, here, let me just give you some formula, not any shared decision making. And just as an example, a 10-year period in Nevada showed that despite many initiatives within the state and healthcare settings, few changes were seen in provider knowledge or skills. This is exacerbated for the active duty woman who faces not only expected breastfeeding challenges, so that lack of family support, physical pain and damage, socioeconomic challenges of making leave different from a cohort in a different branch of the military, but also very unique challenges. And an example of that is temporary duty assignment. For those who do not know what that is, it's sort of a key point there is that a temporary duty assignment might be that if a servicewoman has a goal to go through a training program, she may not get to have her infant with her for that training program or for a field training exercise. A nurse, so therefore even an officer that I worked with, for her to continue her nursing program, she went back to work. So her duty station 3 days after her cesarean birth without her baby. So she was separated from her baby almost immediately after birth. So this does impact obtaining the support needed for success in an individual's infant feeding goals. So we're not supporting our active duty service people in their goals. So the purpose of the guideline itself, this is going to be several slides. And there are, it's a sort of an overarching umbrella purpose that gradually pins down to sort of a narrower focus. It was created with the intention, of course, to empower military clinicians in closing the practice gap that we saw as an obstacle, helping families select their own best infant feeding practices that are going to work for them, so shared decision making. The purpose was to integrate that unique emphasis that the military has on troop readiness with objectives from the IHI's triple aim, and again becoming the military's quadruple aim, 1, 2, 3, 4. Another goal was to create a guide for providers at the military treatment facility level and utilization of current policies that exist, proven strategies that they can use to increase success rate of active duty military mothers who make the decision to breastfeed their babies. In addition, breastfeeding support is, of course, considered an essential aspect of maternal child care provision. A key point, as far as our equity lens goes, is that stable employment, increased education opportunities, and universal health care, which includes lactation consultation, however difficult that may be for an individual to access through the TRICARE benefits system, which is why providers need to be aware of it. Those have all been suggested as factors related to reduced racial disparities in breastfeeding initiation rates for African American and other active duty women of color serving in the military. So it can decrease some of those healthcare disparities that we see in the broader population and the broader social structure. The breastfeeding support in the active duty military population should also guide providers in that holistic approach of understanding that transitioning from one patient they might see as that pregnant and laboring woman shouldn't be considered in a silo when you end up with two patients or more potentially, as the twins on my slide show, the feeding dyad or the feeding triad. So now they're a unit still, and they really shouldn't be seen as separate issues in silos of care. So individual mothers, babies, or parents and babies, mother-infant dyads, triads, etc., military families, the military or civilian providers who serve them, all of them can experience the benefit of guiding principles that are based on evidence-informed practice for health and wellness, starting directly at birth. Excuse me while I page through my notes here. So what are your stakeholders? What are the entities that are going to be benefited by this? If you take a moment to think about what that might be in the outside setting, you're thinking the hospital, insurance programs, etc. But in the military health setting, so the facility itself is a stakeholder entity. So not only just the family, the baby, the mother, the family structure, but the TRICARE benefits program. So that's the equivalent of an insurance program in this setting. The DOD and the DHA and the entire country should be positively impacted by adoption of a guideline that improves and guides lactation assistance for active duty service members in this unique environment. So, synthesizing best practices for lactation support with the military policies that already exist should foster that continued growth of a system that currently verbalizes its pride on expanding to meet the needs of members, should provide standardized training to staff that moves across flights, which is the equivalent of different units. So somebody moving from, okay, I worked in mother baby and now I work in urology, can still benefit from understanding appropriate feeding practices. An example might be, I'm sure you can think of them, take a moment. My example would be something like, I worked in mother baby, I understand the importance of breastfeeding. There are very few medications a parent cannot take when breastfeeding. So therefore, when I moved to urology and this woman is given an antibiotic for pyelonephritis or for just a urinary tract infection, she does not have to pump and dump that milk. If she's going for a radiology exam, she does not have to pump and dump her milk. So that understanding will broaden perspectives even when the personnel that's providing the healthcare moves into different branches or different flights, or as they might say, different hospital units. So overall, the attempt here is, or the intention is, provide guidance to improve success rates, however that's interpreted by the mother, the family. And this should be seen throughout those pertinent departments. The guideline itself has been independently validated by a panel of experts. It was a 5-person panel. They were selected based on military healthcare system experience, professional use of evidence-based practice throughout their careers, and individual lactation expertise. When you look at conceptual theories and frameworks, not everyone watching this is going to be a nurse. You're coming from different healthcare perspectives. What I used was a nursing framework when I was designing this project, and that nursing framework accounts for different complexities. Take a moment to think about those complexities, all the different influences on health promoting behaviors. We have preferences, demands on time, influences, family perspectives. All of these things influence what is going to happen within this family, with the dyad, with the broader family perspective. When you take that framework and then you include a theory of diffusion, use Rogers' theory of diffusion of innovations, that's the concept where you might have heard people talk about utilizing their breastfeeding champion or their evidence-informed practice champion within a setting. And many of you, maybe all of you listening to this project may think of yourselves, and you probably are. You're the breastfeeding champion. You're the innovation in working with families to meet their goals. This is the next couple slides. I'm just going to zip through, just gives you a picture, a model of what that health promotion looks like and how those different influences work amongst each other. And then how you take that diffusion of innovations with the folks who are your adopters and your early influencers and work within a system to promote the change, the systems change and the policy change that you're working towards. So just thinking about what we know about breastfeeding and lactation, of course, there are complexities and difficulties that are common for all women. Pain, you know, people tell them you can or cannot take this or do this or eat this, whatever you might think of, and then add on top of that the difficulty of things like the military active duty person that has to go on a training, a field work, exercise, something like that, that's going to make her think, or make the family think, we can't get through this, so it's just going to be easier to do something else, to bottle feed my baby, or to formula feed my baby with a bottle. However, improving breastfeeding management requires that framework, or a framework that you can use to accommodate all those variables, all those influences that she is facing. This is her career, her work-life balance. And then dissemination requires use of those early adopters of innovations to encourage use throughout a facility. So that's where your systems change is influenced. And that really does have to come. You can put the policy in place, but that must come from the ground and move upward and umbrella out. So just really quickly, I'm going to sort of review sources of evidence. Did include, I use standard search engines for scientific research, and different Boolean search strings, or strings of words, to find military policy, breastfeeding guideline type policy information. Articles greater than 10 years old were used when you go and access the evidence-based practice guideline itself and review it, to understand within the context of the military health system through time, in the context of the changing healthcare climate in the military. Of course, there were references, national and international expert bodies to comprise consensus opinion, and the importance of general management, cost analysis, risk reduction, the things that you need to use to encourage adoption of a policy from the top down so that you can work from the bottom up. And then of the 30 articles found that included both US military, which was the target of the capstone specifically, and breastfeeding, 21 were from the last 10 years in publication, and 11 were from 2015 or later. So that's the most current research that I could find. Grading of evidence was used, done using Final Overholt's hierarchy of evidence, and that can be researched and looked up. It's also included and explained in the guideline and in the information itself. So when we move on and think about how each of us takes evidence-based recommendations, and we analyze those things and we synthesize those into our practice. So think about how you do those things, and I especially appreciate any feedback or things that you thought of that you might want to email me or contact me with on how that can contribute to expanding this project and making it more usable and user-friendly. Basically, what I did was take the authoritative bodies, the consensus opinions, the importance and understanding of the importance of lactation support, and then the diverse breastfeeding perceptions and policies both within and outside the military health system, and attempted to integrate them into this guideline. So all that was sort of synthesized to try and make it a little more usable within the military health system, and particularly at the military treatment facility level. So basically, think of the military treatment facility, that's your hospital. So moving on, I'm not going to take a huge amount of time to explain the different slides. You can read those for yourself, but the overall method design and participants and implementation, that was guided with a very specific document that I had to use through Walden University, from which I graduated for my doctorate. Best practices were included, in-depth literature review, and then the creation of the document was targeted to the unique needs specifically of the active duty servicewoman, while thinking about how that could be utilized with any active duty service member, but also anybody served within the military health system. And while I made every effort to minimize agenda-driven bias, including understanding the informed decision-making for how an individual mother or family wants to feed her infant and child, that doesn't mean that bias doesn't exist. I don't think it's possible to be completely bias-free. Looking at the evaluations, the comments and the came from my 5 respondents that were again selected for their experience in lactation. Simple descriptive statistics was all that was needed to coalesce the commentary from those respondents. There were multiple questions on the questionnaire, which was submitted to them and then back to me anonymously. There was an independent answer to question 3, which you will see where somebody was able to create almost a number 6 on the 1 through 5 Likert scale. So the applicability was seen to be highly likely across the different, what we call the units or flights of the hospital or an individual military treatment facility. Having said that, it was also likely that it would be applicable across branches because, again, branches, healthcare wouldn't be different or shouldn't be different, but currently is somewhat different across branches. Question 3, that philosophy of advocacy for breastfeeding support. And take a moment to think about why that might be difficult. I'm sure you can think of some reasons why that is difficult when you're just dealing with individual providers in whatever setting in which you work or provide volunteer support for families and their breastfeeding goals. That philosophy of advocacy, the policy can be here, but again, unless you can work from the bottom up in innovation and helping folks to change and understand that perspective, it's not really going to work. So there is a difficulty in thinking about how that is going to be received among healthcare providers. As we've seen with baby friendly, you can tell everybody, yeah, we're going to be baby friendly. It doesn't stop the nurse in the middle of the night from providing a pacifier to a baby or offering to take the baby out of the room so somebody can get some sleep, et cetera, et cetera. So that's difficult to overcome. And then when you think about dissemination across all facilities, while the applicability was seen by my respondents, that it should be applicable across all military treatment facilities, again, the biggest problem may be just getting people to sort of buy into that. So that's where all of us, anybody who's probably attending this, becoming the advocate and understanding how that diffusion works and how the information works and correcting false information and myths about breastfeeding. Some general comments from the anonymous survey are included here for you to look at. Again, implementation, because of pushback potentially from different individual providers, groups of providers, or leadership, may actually be the implementation concern. However, I did receive very positive feedback from folks that it was, from my respondents, that the information itself should be applicable and usable for evidence-based, concrete, specific recommendations that could be used. So just pausing for a moment. So implications for making that broader policy possible. Think about how we've struggled with implementing baby friendly, for example, within the United States itself. And I think that's where we may run into trouble. So I'm sure if you take a moment, you can sort of question where would be my problems with implementing a policy like this across the board. And so that's the implication of attempting to do something like this. So again, that key problem may be overcome partially by providers and leadership, emphasizing to your leadership in your given setting. You may find a different reason for this, but for me, letting providers and letting leadership know that higher retention improves mission readiness, that may be one of our best sellers, as it were, or innovations for them to think about in this case. So things that I did do for recommendations, and I welcome more recommendations from all of you. When this went out, I did receive some feedback also on using the 10 steps of the Baby Friendly Hospital Initiative from the World Health Organization, rather than ones still in use from Baby Friendly USA. They're still using an older iteration of the 10 steps, and some of the supposition on my part is that data continuity issues may be problematic, as some of those steps have changed a little bit within the World Health Organization, making it harder to track across time how those 10 steps are being implemented. So that's the theory on that. I did also directly from Robin Roche-Paul, who contacted me separately from her anonymous questionnaire to let me know that I could provide anyone reading or downloading this capstone project project with her contact information. So it is there within the project and within the reference list to contact her for the most current possible list of known military policies on lactation support, because they can change rapidly or be tweaked. And so her contact information will be available to all of you. Think about what strengths there might be in such a policy, and then the strengths in knowing that I completed this project within the military health system during clinical rotations for my doctorate. So what strengths does that lend to a project like this? So if you pause for a moment and think about that, what I found was firsthand insight into breastfeeding experiences during that clinical rotation. So hearing both active duty and civilian families talk about their experiences with breastfeeding support, both at prior military installations and at the J-Bear military treatment facility on the ground there. The other strength that I feel serves this project is that the expert panelists do have lactation experience, totaling decades. They've served in the military, experienced the life of a military spouse, or have a military family member. Some of them actually have all three of those. So while the 5 expert panelists do number only 5 at this point, they did all respond, and they do have significant experience in the setting, including historically. Now go ahead and think about for a moment what limitations that you see, and I am sure that you can see some that I have not thought about, and I welcome feedback about that as well, what things could be done to decrease the limitations of this project. One of my concerns is a lack of large-scale research across the entire military health system. When you look at the references, there are not large-scale studies done at the same time asking the same questions across the health system on lactation support and difficulties experienced by servicewomen. So generalizability is assumed rather than known at this time for this project. Other than interacting with active duty providers at the MTF where I was doing clinical rotation, I was unable to obtain contribution of active duty staff to the project. This is mainly related to limitations. Think of HRPO, or Health Research Protection Office, as a more stringent IRB than what you might think of as your routine IRB. They did not want me to send out this questionnaire, this anonymous questionnaire, more broadly at the time. So I'm hoping that the DHA will be able to do that. So, and again, the respondents number 5. The diversity, the inclusion is not nearly as broad as I wanted it to be. That number, however, was dictated also by the structure of the project within Walden University and getting permissions and IRB approval through the university. It is being disseminated through the DHA, the Defense Health Agency, so what is going to be eventually the umbrella organization to coordinate healthcare across all military branches. The lactation working group within that is what I'm trying to work through to expand dissemination for feedback and for inclusion of this research. I'd like to, once we are through the COVID-19 pandemic restrictions, to consider the Military Health System Research Symposium, because I'd be reaching the folks on the ground who may be able to provide policy changes. The site actually already has the guideline that they can start looking at and thinking about implementation, since they don't even have a policy on site at this point. USBC has provided a platform, and this has also been submitted to other platforms to make this more widely available to all of our early adopters out there that I'm speaking to, and our supporters, our champions that are watching this, are listening to this. And then some journals may be able to publish some of the information as well. So in additional thoughts, this is where, again, you come in. What additional thoughts do you have? Feedback, ideas for this project, and again, you may need to download and review this. It's far too lengthy for more than a 30-minute, that would require more than a 30-minute presentation to go through the guideline in detail. But for me, what I found was the importance of inclusion. The diverse family structures in the military setting is perhaps more surprising than we have seen historically. Same gender families, mixed families from the standpoint of families that are multiple military member, multiple active duty families, merged families. There are just so many diverse family structures in the military setting, more than you think of from the old don't ask, don't tell that you used to hear people talk about in decades ago. Breastfeeding parents also may elect a variety of feeding methods. And so when you're, of course, talking to them and approaching them, that unbiased approach and that equity lens really has to be utilized. In any military treatment facility, you're not talking about the local culture. You're talking about the local culture influenced by everything that they bring with them from their home communities where they grew up. So families bring such a variety of experiences, life experiences, and world experiences with them. And again, survey dissemination to a broader range of both health personnel in the military system, peer support groups that service the military setting, soldiers, airmen, seamen, all of the different Marines, all of those different groups, the uniformed services or the health corps, and their different experiences in experiencing their policies, how they experience the actual support from their current structures. And then in summary, just I'm going to reiterate, those challenges for servicewomen are consistent with what other working women face. So we're talking about working women who have elected a career in the military. And so it's a military career, but it's also merged with whatever their particular career field is. My daughter, being a military servicewoman, she was stationed in a radiology department and she's getting training in radiology. There are women, though, who are stationed working with fuels. So there are women who are working in maintenance. There are women who are working in logistics. There are service members who are attempting to breastfeed or who are breastfeeding, who are working in all sorts of jobs. And then their job is also military readiness and the military itself. Meeting feeding goals and feeling supported is probably a desire of every mother and family, regardless of their status as civilian or active duty personnel. And that, again, that broader perspective has to come into play here. Lactation and support of lactation is a global issue. Service women can be stationed around the world. Their healthcare providers are stationed around the world. And they service not only active duty members, but also civilian populations that might include with military training, that might include in war zones and interacting with civilian populations and providing healthcare to those populations. So that broader perspective and that equity lens is extremely important. And I still have so much to learn about that myself. Adoption of a military-wide or a Defense Health Agency system-wide evidence-based practice guideline definitely has the potential to impact maternal child care on a global scale because of all of these issues, from where people come from, merging into a community on a particular base, which might be different from the culture and community on another base or station, or if somebody is sent to on a mission somewhere across the globe. And so that all has to be taken into consideration. In closing, I just really, really want to thank everyone who elected to watch this presentation or listen to it. I want to really thank the United States Breastfeeding Committee for providing a platform that I think is just a wonderful, safe platform for feedback, and I welcome that feedback. Here is my email address, hkoslo@mtaonline.net. So if you have questions, concerns, feedback. You can't access the full capstone project and evidence-based practice guideline, which are all in one document. Via EBSCOhost, you don't have access to those kinds of services. They can be difficult to obtain if you're not associated with a training facility. So I'm happy to send them to you directly and provide that for your reference directly. The reference itself includes, it's close to 100 articles and things, so that you can access all of that when either you download or I send you this capstone project or dissertation. But that can be accessed through this particular reference that you can copy down or take a screenshot of, etc. And again, thank you for the opportunity to share. I am just so happy to be part of USBC's Reimagined conference or convening this year. I was looking forward to Scottsdale, but this is a fabulous idea to take its place for the time being in our current world situation.